Hello everybody. Today we are going to start with a respiratory system anatomy physiology. We start to talk about a few things. If you see here the tennis court is if we expand all the alveoli of the lungs, you will see that you have an area similar as the tennis court. So that area is the area where you have all the gas exchange. So another thing, we have two lungs, as you already know. As interesting thing is that we are going to have about 350 million alveoli in each lung. So that means that we have about 700 million alveoli in both lungs. So alveoli is, in Latin, means little cavity, and this is the functional unit of the lung, that is the alveolus. Okay, the alveoli, we have the alveolar and the terminal bronchiole are going to be the functional unit of the lung. Is what we call the sinus. Okay, so what is the primary function of the lung? The primary function of the lung is actually to maintain the levels of gases in blood in order to keep the metabolic demands that we have in the body. For example, oxygen is the main thing. Oxygen, we inhale, as you can tell, about 6 liters per minute. And that means that we have, I make the calculation, about 9,000 liters per day. You already know that the air has about concentration of oxygen about 21%. 21% is the air that we have in the outside environment. 21% is getting into the lungs, and we exhale. The amount of oxygen that we exhale, I said oxygen, is going to be only 15, 16%. So that means that we have only captured 5% of the air that we inhale each time. So that means that we use a day about 500 liters of oxygen. All right, so let's not keep waiting. We are going to continue with the first slide. So here, first of all, we need to know the basic thing. What is respiration? Respiration is the process of getting oxygen from the environment and delivered to the cells. That is the whole thing, right? So we inhale oxygen and we are going to deliver to the cells. So, but we have three phases. Okay, the three phases, we have the pulmonary ventilation, the external exchange of gases, and the internal exchange of gases. So pulmonary ventilation is the same to say the breathing. How is your breathing? So in this breathing, what you are doing is the gas exchange, okay? All right? So that means that you inhale oxygen and you exhale carbon dioxide. So that is the pulmonary ventilation, how your thorax is moving to bring in, and breathe out. Now we have the second phase, is the external exchange of gases. That, first of all, in the pulmonary ventilation, where is the gas exchange? Mostly is in the between the lungs and the outside environment, the environment and the alveoli. So how the air or oxygen is going to get inside the alveoli. The external exchange of gases means the exchange of gases between the alveoli and the blood. This is the next level. And the third level is from the blood to the cells. So I have a small cartoon, I just made it. So we have the environment, alveoli, capillary, and the cell. So environment is outside, they go to the alveoli. From the alveoli, they go to the capillary, and from the capillary, go to the cell. So environment and alveoli is going to be, from environment to alveoli, ventilation. Alveoli to capillary, external respiration, and internal respiration from the capillary to the cell. So that is actually the summary of that. Let's talk about pulmonary ventilation, and Pulmonary ventilation is nothing else than the breathing. If you see here the cartoon moving there, we are going to talk about compliance. Compliance, that is very important to remember, because that is the ability where the lung is, how easy or how difficult is going to expand during the inhale of air. Okay, is the change of lung volume caused by changes in the intrapulmonary pressure. So how easy is going to expand or contract the lung? That is one of the main characteristics of the lung, and we are going to see in some pathologies, for example, the pathology of the lungs are going not able to have enough compliance, so compliance are going down. All right, so talking about pulmonary ventilation, we have inhalation, inspiration, and exhalation, exhalation or expiration. What we need to remember is this. Inhalation is the active phase, active phase. Why? Because you are using your diaphragm in order to inhale. When you inhale, what happens? The diaphragm is going to contract, so it's going to get flat. So when you get the flat, is going to make more space in the thorax. So that is the active phase that because the diaphragm is working at that moment. So please remember is that the most important muscle for inhalation or inspiration is the diaphragm. Is the diaphragm. And the other one, exhalation or expiration, is a passive phase. And remember that, please. Most important is the intercostal muscles and abdominal muscles. So the most important muscles for the exhalation or expiration are going to be the intercostal muscles. And for inspiration is the diaphragm. You can make right now some breathe in, and you know that you can do it because diaphragm is going down, and this diaphragm going down means that it's contracting this diaphragm and make more space in the thorax. Then when you want to exhale, basically you don't have to do any effort. Why? Because the muscles are going to relax and they create a negative pressure, and you are going to be able to exhale without any effort. So that is the passive, that's why it's passive phase. All right, so here we have the inspiration. What happened with the diaphragm is going to contract. So you here we have the diaphragm contract. You see, first of all, this is breathing in, breathing out. So just to visualize, this lung is bigger than this, right? So that means that this breathing in and this is breathing out. So that's what this diaphragm, what it's going to do is to make it almost flat muscle. And when they make flat is because they are contracting. Contracting means that it's going to lower the diaphragm as this arrow to expand the thorax. So the diaphragm contract and the expiration is going to relax. When they relax, the diaphragm is going to have this shape like a dome and decrease the thoracic space. Why? Because they're actually exhaling the air from the lungs. Chest cavity volume is going to increase when inspiration, expiration is going to decrease, and the intrathoracic pressure is going to be accordingly to the volume. More volume, more pressure, less volume, less pressure. Okay, so let's talk about gas exchange. Gas exchange we have is the diffusion of movement, is the diffusion and movement of molecules from higher to lower concentration. That's what we were saying in class many times, that the universal law is since that making things going from higher concentration to lower concentration to make it at the end even, right? For example, here we have the external exchange of gas. The external exchange of gas, we have more oxygen coming into the alveoli, right? And what is going to find the alveoli? Because the alveoli is surrounded by capillaries. And these capillaries is going to bring blood with low levels of oxygen. So that's why alveoli with high concentration of oxygen is going to make the oxygen pass to the capillary capillary vessels. Then we have the internal exchange, is the gas move into the blood and tissues. And the same situation here. So the oxygen is going to be very high concentrated in blood, in the arterial blood, and when they irrigate the cell is having low levels of oxygen, so that means that the red blood, the oxygen is going to pass from the capillary to the cell. So everything is going to be through simple diffusion. So what are the two phases of breathing? You already know is inspiration and expiration, which is the active and which is the passive. So you already know that the passive is going to be the exhalation and the inhalation is the active phase, right? Okay, gas move between the alveoli and the blood by the process of diffusion. What is the definition of diffusion? Think for a second. And diffusion is the the passing of the expansion of a substance from a higher concentration to a lower concentration area, right? Okay. So here, just make a small review here. We have the upper and the lower respiratory tract. I want just you to remember that the nasal cavity, we up to down to the larynx, that is the Adam's apple, including the whole Adam's apple, larynx, is the upper respiratory tract. Meantime, the lower respiratory tract is between the trachea and the alveoli. All right, so let's start with the nasal cavities. The nasal cavities is going to be in each side, we already know, of the nasal septum. Septum is the division that is in the center of the nose. And that is going to be the, if you see here in this picture, the nasal cavity. Okay, so if you see the respiratory tract is going this way down, right? So why I'm saying that? Because when you are going to put some, for example, nasogastric tube, nasogastric, right? So most people, they put a cannula all the way up like this, but it should be always horizontal. Why? Because they go all the way down. And here we have the respiratory tract in front, anteriorly, and posteriorly of the trachea or respiratory system, we have the esophagus. So let's focus on the nasal cavity first. In the nasal cavity, we are going to start talking about the nostrils. The nostrils, right? So those are two openings on the front on the nasal cavity. So actually, what I want you to remember is technically, when we refer to the nose, we talk about nostrils. Nostrils is very common, or nares. That is not so common, but we can use that name too. But nostrils are going to be the more technical name for these openings. We have the nasal septum. The nasal septum, if you see here a sagittal view of the cranium, we have first of all a cartilage. So this is cartilage. The tip of the nose is a cartilage. It's not really bone. So that's why you can move your nose with your finger, and that is cartilage. So when they go some plastic surgery or something, they remodel this septal cartilage in order to have the shape they want. Behind that, yes, we have here the bones. We have the partially the ethmoidal bone, bomber. We have the nasal bone. We have different bones that we just going to be part of this portion. So, but the center, that is called the division. So you divide the right from the left. Here we have in the nasal cavity. Just I want to use this time in order to remark something here. This is the cardinal nerve number 1, is the olfactory nerve. And you can see here that the olfactory nerve are coming from the central nervous system, and they go some ramifications here on the nasal cavity. So in the nasal cavity, we are going to have different structures. This is the mucus. So you can put your finger inside your nose, you touch mucus. That is going to be innervated by the olfactory nerve. plus we have arteries, veins. All right, so let's talk about the mucous membrane. The mucous membrane is the lining of the cavity that covers the nasopharynx. So we start to talk about the nasopharynx. And all these mucus are going to cover many structures. And this is characterized by the pseudo-stratified epithelium. And here we have the goblet cells. This is the goblet cells that we have the pseudo-stratified cells with the cilia, and this cilia is going to have a movement activity that is going to sweep out the bacteria that we are going to see in a few moments. And here we have the goblet cell. So this is pseudo-stratified cell, another pseudo-stratified cell, pseudo-stratified cell, pseudo-stratified cell. This is a pseudo-stratified cell but was modified, and this is going to change into the goblet cell that produces mucus. Mucus, remember, is important. Mucus is going to contain a protein that is called the mucin. Mucin, very suggestive name, mucin. And this mucin is going to be with fluid that is going to make the mucus. So here we have the cilia and the mucus in different perspective. So it's covering the mucus and the cilia is working below. So well, open eyes, open ears here, please. These mucous membranes are going to pseudostratify epithelium, filter foreign bodies, is going to warm air and moisten, is going to moisture the air. So we don't want dry air or on your nose because it's going to get dry and so you can have some cracks. So the same thing for people who having oxygen for some periods of time, they receive oxygen with one humidifier, so that is going to moisture. So the air that or oxygen that the patient is receiving is not going to be dry and probably crack the skin. So that is how approximately is working. This is the cell membrane here. This is cell membrane. This is the cell. This is the cilia of the pseudostratified epithelium. This is the mucus produced by the goblet cells, and that is what is doing the cilia and the mucus. So they are going to just sweep out everything. So this is the outside. It's going to sweep out all the dust and bacteria that can get into the nose. All right, so let's talk about the turbinates and the conchae. Turbinates are going to be structures that are located in the nasal cavity. Can you see these turbinates? These turbinates are like small mountains, let's put it this way. And these turbinates are going to be covered by mucus. So there's different bones, the ethmoidal bone, the nasal bone are going to form the reliefs of the turbinate that are going to be covered by mucus. So these are very important. Why? I will tell you in a few moments. So first of all, we need to know the anatomy. Here we have the turbinates. All this protrusion, bulging area is called a turbinate. This is the superior, middle, and inferior turbinate. Okay, so that is one thing that we need to remember. And here we have the part of the frontal cut of the cranial face, and we have this area where we have the superior concha, this part of the bone, ethmoidal bone. This is the inferior nasal bone. So different bones can produce the frame, the bony frame for that. Then it's going to be covered by this mucus. And you have the superior, the middle, and the inferior turbinate. So now let's see inside the nose. So if you have some device that can make open your nares, right, your nostril, are going to see this structure. So these structures that you see like a bonding area are exactly this. So if you open here, you're going to see this structure that is the inferior turbinate, and that's what you're seeing here. So that is inferior, and this is the middle turbinate that you can see easily with that instrument. Okay, so let's leave a little bit the turbinates alone, and we are going to come back and put everything together again. All right, so we have sinuses. So number 5, sinuses. Sinuses are cavities. Can you see the cavities here? A pair of cavities, another pair of cavities, another pair of cavities, and another pair of cavities. And here we have the frontal, we have the maxillary, we have the ethmoidal, and here in this draw should be drawing, but here we have in the sagittal the sphenoidal sinus. So we have right and left. It's not only one, it's two. So everybody is two. Two frontal, two ethmoidals, two maxillaries, and two sphenoidals. And what I want just you to remember here is what is the largest one? Open eyes, open ears. The largest one is going to be the maxillary sinus. The maxillary sinus. Okay, so here we have again the sinuses. So we have here the frontal, the maxillary, the ethmoidal, and the two sphenoidal. Can you see one and two sphenoidal? And we have here two groups, one group and another group of ethmoidal, sphenoid. So if you see a little bit with detail, you can see here the maxillary. In this picture, there is a connection. If you know a little bit here, we have this curve this is the septum of the nose. Here we have the turbinate, the superior, middle, and inferior. The superior is not seen very well, but in superior, middle, and inferior. So the turbinates that we saw in the previous slides, if you remember here, right? So now, what is doing these sinuses with this nasopharynx or nasal cavity? All these sinuses are going to drain into the nasal cavity, all of them. So the frontal sinus drains into the nasal cavity. The ethmoidal, sphenoidal, and the maxillary are going to drain into the sinus cavity. So can you see here the turbinates again? And here we have all the sinuses we was mentioning. Here the sphenoidal sinus, and the largest one again is the maxillary sinus. Don't forget that. So here again a clear more picture. We have the turbinate here. This is turbinate, and this turbinate is here. What I mentioned with put my arrow here is the nasal cavity. But here what we have is sinuses. The maxillary sinus, the largest sinus from all the body, from all the cranium. So can you see it's communicating? So the maxillary is going to communicate into the nasal cavity. This is important. Why? Uh, don't forget that the frontal, sphenoidal, ethmoidal are communicated to the nasal cavity. But what happens if you have a cold or if you are having some obstruction in this area where my arrow is? So here is fluid, and here is going to be fluid that they are going to get trapped here and produce sooner or later an infection when this is blocked. And this infection is going to produce the inflammation of the sinus called sinusitis. So that means that can produce an inflammatory and infectious disease. Sometimes we need to drill over the cranium in order to drain the pus from there. There's another procedures, but definitely is a serious stuff. Okay, so let's keep going. So here we have the frontal sinus, where it's going to drain into the nasal cavity. Where is the ethmoidal sinus is going to drain into the nasal cavity. Maxillary is going to drain into the nasal cavity. So you will see many times that a person who is coming with some problems of sinusitis, you just touch the area where you superficially you will see on the top of the frontal sinus and the maxillary sinus. If you touch superficially with your finger, the patient is going to have pain, areas of localized pain. So that is one of the signs and symptoms of sinusitis. So here we are going to see let me see if I have something. All right, so here we have the frontal sinuses, as you see here. We have the maxillary sinuses, and see the connection with the nasal cavity. We have the ethmoidal sinuses, And here posteriorly we are going to have the sphenoidal sinuses 1 and 2, 1 and 2, and they are going to in contact with the nasal cavity. So here we have the septum, we have the turbinate. Here you can see the flow of the air and fluid that can drain from frontal, this is the maxillary, into the nasal cavity. Okay, and they are going to drain there into this area. So when they get inflamed, they are going to get blocked and they are going to be full of fluid. And that means that is called as sinusitis, produce very much pain. So they cannot drain into the nasal cavity. Okay, so let's see. All right, so all right, so here we have some nasal endoscopy. So this tube is put it into your nose, and they are going to explore the area. So here's the machine. You see the monitor there is checking what is the camera, the distal portion of the tube is going on, and that is the first view. So you are going to see, can you see the mucus of the nasal cavity? That is pseudostratified epithelium. The pseudostratified epithelium, they go all the way down to the bronchioles, and there are some variations, of course, but definitely they are going to have that. So here we have endoscopy being done. So this is the nose, this is the hair of nose, and this is the entry into the nasal cavity. You can see the mucus, and you can see the turbinates already. One turbinate, another turbinate. Those are foldings. The frame is a bone, but it's covered by mucus, and that is the turbinates. Okay. All right. So what are the meatus? Okay, meatus are spaces. So meatus is a space that is the entry or the exit of something. So, for example, urethra, this is meatus, is the urine coming out, right? Here we have in the nasal cavity, we have again the superior concha or turbinate. Concha turbinate is the same. Another turbinate, middle, and inferior turbinate. And here we have the superior meatus, middle meatus, inferior meatus. So these meatus are channels that are going to drain something into the nasal cavity. And these drainage meatus are going to drain from where? From the sinuses. So that are the openings. Meatus are the openings of the sinuses into the nasal cavity. For example, the superior drains the ethmoidal and sphenoidal sinuses. The middle drains the maxillary and frontal sinuses. And the inferior is going to drain the nasolacrimal duct. Yes. So the tears are going to drain into the nose. So in the eye we have a canal, a channel that is going to take the tears when we cry into the nasal cavity. So what is draining here is going to drain the sinuses and the nasolacrimal duct. So I don't want you to remember the superior, what is draining the superior, in the middle, inferior. No, just overall. And overall, I want just you to know that they are going to, the nasal cavity is going to receive the drainage of all the sinuses, frontal, ethmoidal, sphenoidal, maxillary, and the lacrimal canal, period. So here we have another view where you can see the meatus. This is the nasal cavity with the turbinates, and here we have the frontal sinus that is going to drain into the nasal cavity. Here we have again the sphenoidal meatus is going to drain here, and another ones that I have not seen here because it's totally it's a sagittal, mid-sagittal plane. All right, so just to prove here, where is the gland that produce tears? The gland who produce tears is here is in the upper right, upper superior outer quadrant of the eye. So the outer superior quadrant of the eye is where you have the lacrimal gland. The lacrimal gland is going to make distribute on the eye, and the tears are coming this way, and they are going to get into the lacrimal canal. Lacrimal canal. This lacrimal, so the tears are coming this way, go to the lacrimal canal, and they drain in where? Into the inferior nasal meatus, that is the nasal cavity. Okay, all right. So here again we have another view. This is the, if you see these two, if you see close to the mirror, there's two dots there, and these dots are where are coming the tears out, and they are going to drain. There's two channels, not even one, it's two. They are going to drain into the inferior inferior meatus, that is the sinuses. Okay, the nasal cavity. All right, so that is about, remember the turbinate. We have the septum, that is the division of the right and left nostril. And here, let's see, we have the meatus and the turbinates. All right, so what is this? This is the sphenoidal sinus. What is a little bit here? We see the frontal sinuses you see here. See the frontal sinuses, and this is the sphenoidal sinuses. All right, so let's keep going. All right, so let's talk about the paranasal sinus, and that we already talked about that. Look at this. We have the frontal, we have the maxillary, the sphenoidal, and the ethmoidal. This is must, you need to remember. And what are doing these cavities in the head? Why we have cavities in our head? Number one, because they decrease the weight of the cranium. They're going to decrease the weight of the cranium. They are going to have the resonance, is a resonance chamber for your voice. For example, if I close all the cavity, you're going to hear me like I have a different way to talk, right? So I'm covering all the sinuses with closing my nose. So you can see the difference. So that cavities are going to keep the resonance of your voice, okay? So here we have a sagittal view. So in the nasal cavity, not only we have the olfactory nerve that we already mentioned, the mucus, the turbinates, but we have vessels too. These vessels are coming from those are the ethmoidal arteries. We don't care about the name, just remember that we have some vessels in the nose, and that is where it's coming the bleeding. And this bleeding, when you coming from the nose, is called the epistaxis. Epistaxis means nose bleeding, okay, nose bleeding. We can have problems of deviation of the septum, or sinusitis, that is what is an inflammation of the sinuses. You have a cold, the congestion of the mucus, close the meatus, the exit of the sinuses, and they are going to produce inflammation. Polyps, the vegetations, those are hyper proliferation of the mucus. So these polyps is like a small shape of fungal shape. And it's not a fungus, but have the shape of it's better to say like a finger-like growth of the mucus, and that can produce obstruction of the meatus. All right, so let's keep going about talking about the pharynx. The pharynx is we are going to see that the pharynx is easy to remember. We have three portions of the pharynx. Different books, they call different names, sometimes it's slightly different, but in general, what we have is number one, the nasopharynx. What is the nasopharynx? We're talking about the nasal cavity, right? Easy. So nasopharynx. And we have the oropharynx. Oropharynx, please, here's the teeth. This is the maxilla. This is the mandible. And here's the tongue. Here the muscles. So all this is the tongue. All this is the tongue, and this is the oral cavity. Oral cavity. Oral cavity is the oropharynx. And the oropharynx we have down to the larynx. The larynx, including the whole larynx, including the larynx is the Adam's apple, including all the larynx is going to be the laryngopharynx. So what is easy about this is that all these three together, naso, oro, laryngopharynx, all together as one is called pharynx. Pharynx. This pharynx is subdivided in naso, oro, and laryngopharynx. Okay. All right. So here we have in the enter or exit to the pharynx. So what can enter? What structures can enter or exit from the pharynx? We have the larynx, is the opening here, the larynx. The esophagus is behind. Remember, respiratory anterior and gastrointestinal esophagus is posterior. We have the auditory tubes. The auditory tubes are going to end into the nasopharynx. Remember that, please. We need to remark that. We have in the nasopharynx what they are going to drain, the sinuses, the lacrimal canal, and the eustachian tube. Remember the eustachian tube? Eustachian tube is a tube coming from the middle ear. So all these guys are going to get into the pharynx. Again, so what is getting into the nasal cavity? Number one, sinuses. Number two, lacrimal canal. And number three, the eustachian tube in the nasal cavity. Okay, so that is one of the connections. So if you have a cold, the eustachian tube is going to take the virus, and the virus climbing through the eustachian tube and can get into your ear. So that's why it's so common to have ear infection after a virus infection or respiratory tract. All right, so we have the nasal sinuses and the lacrimal tube. So please open eyes, open ears on this. Nasopharynx. The nasopharynx is, we have, if you remember, the uvula, this small like a bell that is behind the oropharynx. So all this is the oropharynx, okay? Oropharynx. All this is the oropharynx. So what is doing the uvula? So if you see here, where is the uvula here? The uvula is, let me see, this is the uvula. Okay, it's not seen very well here. I will check. All right. So the uvula is, when this uvula, this is cavity, okay? This is the nasal cavity. And here is the uvula. Can you see this pink area? So this is the roof of your, the ceiling, sorry, of your mouth. And here is the uvula, this one. So this uvula, what is the function of this uvula? When you swallow food, you don't want the food going up to your nose, right? So the uvula, what is doing when they are going to, when you pass fluid or solid, this uvula is going to contract and this uvula get here. It's going to go up. And that is going to close the pathway to the nasopharynx, okay? So that is the function of the uvula. That is the function of the uvula. Okay, so then we have the oropharynx, and that is the middle portion, and we have the laryngopharynx, that is the inferior portion, where we have all the cilia already working for get rid of the dust. Okay, so let's keep going. The larynx. The larynx is called the voice box, and this is part of the respiratory tract between the pharynx and the trachea. So it's a transition, but it's still, the larynx is the laryngopharynx. It's part of larynx or laryngopharynx is all the area, and pharynx is going to, larynx is going to be part of the whole pharynx, right? So basically what we have here is the thyroid cartilage. Can you see this thyroid cartilage? You can touch in front of you is the Adam's apple. That is the larynx. What is inside? We are going to find the vocal cords, the vocal cords. The vocal cords are going to vibrate because this is the trachea where it's coming air out, right? from the lungs, and this air is going to make the vocal cords vibrate, and that's why you can make a sound. All right, so what is the scientific name for the throat, voice, and windpipe? All right, so for the throat is going to be called the pharynx. For the voice box is going to be the larynx, and the windpipe is going to be the trachea. What are the three regions of the pharynx? You can answer that. What happens to the to air as it passes over the nasal mucosa? What happened? What happened is that it's going to get warm, it's going to moisture, right? And that is going to do when the air is passing through the nasal mucosa. Okay, so larynx content. So this is the larynx. So here we have the thyroid cartilage with it's called the Adam's apple. You can tell here, looking here, please. This is not the thyroid cartilage. You just touch the Adam's apple, and that is the area of the thyroid cartilage. Okay. The vocal cords. We are going to see the vocal cords. If you open the mouth, they even sometimes some people can see the epiglottis and vocal cords, and these are the vocal cords. It's like a violin that they are going to just vibrate with the pass of air, and that make different sounds. Okay, so where is located? In the larynx, inside the larynx. Okay, so if you see this tube that we was talking here, okay, this is the thyroid cartilage. That is the frame of the larynx. Inside, we are going to have the vocal cords, the glottis. So this is very important. So here, this picture, we need to focus on this picture. Here we have the anterior, this is anterior, this is posterior. Anterior, we have here the respiratory tract, this is the trachea. And here we have the esophagus. So anterior respiratory system, posteriorly this tube is the esophagus. So this area is this is an epiglottis. Can you see? It's like a door, like a door. This door is going to close this area. It's going to close what? The respiratory tract when the food is passing. So when you swallow, in other words, when you swallow this epiglottis, what is here, epiglottis, can you see that? Epiglottis, the name. Epiglottis is going to close the door for the respiratory system and allow the bolus going into the GI tract. Okay, so that's why we hear very often, don't eat and talk at the same time because you can choke, right? So you're eating at the same time you're talking. So we need to make a little bit of effort not to get choked, right? All right. So that is the epiglottis. This guy, this structure, the door that is open and closed is the epiglottis. And what is the glottis? Glottis is the space. It's not a cartilage. It's not a bone. It's not a mucus. It's nothing. It's just a space. This space is when the epiglottis open, and this space between the larynx and the epiglottis, that is space only. That is called the glottis. Epiglottis is going to be, if you see here in this picture, we have here the respiratory, and this is the esophagus. All this is esophagus, 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 esophagus. This is the trachea. And what happens is going to close when you are going to pass food. Simple, right? So this is the trachea, and this the airway, the respiratory system, and this is going to be closed when you swallow. Simple, right? Okay, so here we have again the same structure. Here we have the epiglottis. Look at this epiglottis, like it is a cartilage. Here's posterior, we have the esophagus, and anteriorly we have the respiratory system. This is the larynx. It's going to continue with the trachea here. When you swallow, this epiglottis is closing what? The respiratory tract, and the food, of course, is going to go to the esophagus. Okay. Okay, so here we are going to see how the swallowing is happening. So any food or anything that you are going to take, you start to do the mastication. You're going to have the bolus, and look at this. This is the epiglottis. This is the epiglottis, and this is the bolus. This is the tongue. This is the oral cavity. Here it's closed because the tongue is against your palate. Okay, and the food is going to get slowly, is going to get into the esophagus. So this is the trachea, respiratory. Look at this epiglottis. Look at this epiglottis. So it's closing, and the food is going to go posterior to the esophagus without involving the respiratory tract. Okay, so I think it's a very you can repeat it if you want. And then they go to the esophagus and see the epiglottis start to go back to his previous position. Right. All right. So that's good. So here we have another picture of the what is that? That is the epiglottis, right? Where is that? That is epiglottis. So the epiglottis, and can you see these one and two lines? Those are the vocal cords. Okay. All right. So let's keep it going. Trachea. Trachea is going to be a tubular structure. This is from outside, and this is from inside. That is the trachea, and the trachea is formed by cartilage, and this cartilage is going to have a horseshoe shape. Let me see if I have it here. There you are. This is the trachea. This is the membrane. So why? Because this is anterior. This portion is anterior. This is posterior. And posteriorly we have what? The esophagus. So that is, it made it in the way that the esophagus cannot find any restriction for the peristalsis when they go towards the stomach. Right? Nice. All right. So the cells that line the respiratory passage help to keep impurities out of the lung. What feature of these cells enables them to filter impurities and move fluids? Yeah, we are talking about the pseudostratify and the goblet cells, right? The cilia of the pseudostratify and the mucus of the goblet cells. All right, so here we have another name that you must remember here. Here we have the trachea, and the trachea is going to divide into branches, into primary bronchi. Bronchus is singular, bronchi is plural. So this is the carina. This is the carina. This is carina. If you see here, this is the right primary bronchus is more vertical, more shorter and wider. Meantime, the left one is longer, thinner, and more oblique. Remember this point, the bifurcation of the trachea is called the carina. Bronchi, we see we have the trachea is going to divide into primary bronchus. These primary bronchus are going to divide in more segments and many more and many more and many more. How many times the branches are going to divide? Are going to divide between 23 to 25 times. 23 to 25 times. Okay? And these bronchioles are going to be about the number of 35,000 of these terminal bronchioles. And alveoli, we are going to have 350 million each lung. So it's kind of very complicated, but what we need to remember is the bronchi is going to divide until they get into the terminal bronchioles. That is 1/3 of 1 millimeter. That is the size of those tubes. So that is about okay. So here we have all the see, can you see the right is more vertical and more thicker and more shorter, and this longer, oblique, and thinner. They're going to divide and they go to the alveolus. What is the hilum? Another important question. It's a wedge-shaped area of the central portion of the lung where the bronchi, arteries, veins, and nerves enter to the exit. So a picture is better. So if you see here the trachea, this is the carina. that bronchi is going to get inside the lung, inside the lung. So that area where they get inside the lung is going to be the hilum, and I'm going to show you here. If you have this, you cut here and you see what is inside, you will see here the bronchi, we have arteries and we have veins. We have the pulmonary veins and we have the pulmonary arteries. They are coming, going to the, in relation to the heart. If you remember the pulmonary circulation, right? Pulmonary artery is going to carry deoxygenated blood, and the pulmonary veins are going to carry the oxygenated blood, right? Okay, so here we have, so those are the, what is the hilum? Hilum. The hilum is the entry or exit of the structures into the lung. What can enter or exit is going to be the trachea, the bronchi, sorry, the arteries and veins. Okay. All right. So let's keep going. So here we have, if you see here, please, this is the trachea. We have 15 of these rings that is going to measure about 20 centimeters long, and they are going to divide into the primary bronchi. And here posteriorly, listen or look please, this is the esophagus. And here posterior to of the cartilage ring of the trachea is not having cartilage, it's a membrane. And that is because when the food is passing, the esophagus needs to do peristalsis, so it's not going to find any restriction for the peristalsis during the swallowing. Okay, so here we have the lungs. This is the hilum. This is the carina. This is the trachea. Primary bronchi, the secondary, tertiary bronchi, and then they are going to divide 23 to 25 times more. And remember, we have three lobes on the right side. Three lobes, superior, middle, and inferior. Superior, middle, and inferior. Meantime, in the left lobe, we have the left and the lower lobe. The upper or superior lobe and the lower lobe. Superior, inferior, superior, inferior. Superior, inferior, upper or lower, whatever you want. Superior, inferior, we have superior, inferior, same, but we have a middle lobe in the right side. All right, so what organ is located in the middle depression of the left lung? If you you can tell me that in the left lung is going to be in the middle depression of the left lung. It's going to, which organ is the heart? The heart is going to be making some depression on the left lung in order to be localized in that area, the heart. Okay, so let's go to the alveoli. 300 million or 350 million for each lung have we have the alveoli, and the alveoli is having, we need to remember, three types of cells: type 1, type 2, and macrophage. Let's start with the macrophage. Macrophage are like the police. They are going to patrol all the time what is going on in the alveoli, and if they found some dust or they have some bacteria or some virus, macrophages are going to start to kill them. Let's go to the picture, and here we have the type 1 cell. Remember the previous one, type 1. I don't want you to remember squamous alveolar or great alveolar. Just remember type 1, type 2, and macrophage. Okay, and here we have the type 1 is mostly forming the wall of the alveoli. So this is the alveoli here, but this is not alveoli. This is what I'm pointing. This is a capillary that is surrounding the alveoli that is different. But the alveoli is ending here in this dark black line. That's it. So that is the alveoli. See, this is a cavity. Remember, alveoli means small cavities that are going to be formed, the walls, by these type 1 cells. But we have another type, that is the type 2 cells. And this type 2 cells is the one who produce the surfactant substance. So here we have the name, so please write it down. We have the surfactant substance, or pulmonary surfactant. What is doing this is really crucial for living. Why? Because what is doing this is going to decrease the tension of the fluid. It's going to decrease the tension of the fluid. So if you see this is a sac, this is moisture, it's not dry, the lining of the alveoli. So when you exhale, you take all the air out of the alveoli and these walls are going to come together. When these walls coming together, they need to re-expand when you have air again coming in. So for this, we have the surfactant substance. The surfactant substance is going to decrease the tension of the fluid, allowing or making easier to the alveoli to reopen when you have air coming in again. So that is the surfactant substance. Surfactant substance is going to be in the lining of the alveoli. That is going to promote the compliance, is going to promote the expansion again or the reopening of the alveoli. Otherwise, if you don't have surfactant substance, the alveoli, when they squeeze all the air, these walls are coming together, but when you take air again, the walls will not be able to open again. So that is the surfactant substance. And remember, we have the premature babies. Premature babies are called prematures. Why? Because less than 37 weeks, the surfactant substance on them are not in big amounts. They are not being produced completely, so they are not mature. Remember the long maturity of the baby. So that's why it's called premature. So we know that after 37 weeks, the surfactant substance start to complete the full maturity of the lungs. So that's why we divide the fetus in the neonates in premature and a term. Okay, so here we have the, remember the lobes, we have 3 on the right and 2 on the left, okay? We have the lungs, we have the alveoli and the diaphragm. Remember the diaphragm is a muscle that divides the thorax from the abdomen. Pleura is the covers of the lungs. We have pleura on the right lung and we have pleura on the left lung. Each of the pleuras are having a double layer membrane. In between the two layers, we have fluid. In between the two layers of the pleura, we have the parietal pleura and we have the visceral pleura, and the space between the parietal and the visceral pleura is the pleural space. And that is where the fluids are accumulating when you have pleuresia or some pleural effusion. All right, so let's keep going. We are going to talk about lung volumes and lung capacities. And this is kind of a little bit tricky, but we are going to repeat it. I'm going to do it again. I guess I did it in class. Okay, let me see if I have my pointer here. Just a moment, please. I'm sorry, I don't have pointer now. Okay. Let me see if I can do this. Okay. Okay, let's pray that it's going to be okay. All right, so here we have the volumes. Here on this side, we are going to have the volumes. Can you see volume? We have volume, we have volume, and we have volume. Okay, so this is the lung volumes. The lung volumes. This is very important. The lung volumes. The lung volumes are going to be, first of all, let's start with the tidal volume. Tidal volume is going to be this one. That is the amount of oxygen, of air that you bring in and bring out without sinking, right? So the tidal volume. Right now you're having a tidal volume. Then after this, I'm going to ask you to have an inspiration and forced inspiration. So you finish your tidal and you start to have a forced inspiration. Oh no, start. Okay, going to get rid of the pointers and erase all drawings. Okay. All right, so then you're going to have here the this is the type. So we have the forcible inspiratory. Then we have here the expiratory reserve volume is when you end the tidal volume and you have exhale all what you can. But there is a space here that is still we don't use it. They are going to be used for patients who have some respiratory problems. With some exercises, you can make the expiratory reserve volume going down, so you can use more of the residual volume, and that is going to increase at the end your vital capacity, your total vital capacity. So we have volumes here, we have and the capacities here, inspiratory capacity and residual capacity. Very simple. We have how many we have. Let's do my pointer again please. Okay, even though this probably is going to make me have problems. All right, so here we have lung volumes. Start with L, correct? With L. We have the inspiratory reserve volume is I. Then we have tidal volume. We are going to use B. Tidal volume. Then we have expiratory reserve volume. We have E. And we have the residual volume is going to be R. Liver. And what is the word? Is liver, right? Liver. So with liver, you can remember that L is lung volume, the inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. So how many we have here? 1 and 2, right? 1 and 2 are going to be 1 and 2 are going to be the liver, right? IB is going to be the inspiratory capacity, and the ER is going to be expiratory residual volume. Residual volume is the functional residual capacity. Okay, so one of the things that we need to remember is that these are important when you are going to differentiate between obstructive. Sorry, what have I obstructive? Okay, I don't know. Okay, obstructive. The pen is not working. Okay. All right. Obstructive and restrictive. Okay, so it's useless. Restrictive is not working. All right. So we have obstructive and restrictive, and that is the pathologies that we are going to see later. So now you see here we have the vital capacity. Another question important is the vital capacity. Vital capacity is all the volumes except the residual volume. Okay, so vital and total lung capacity is everything from here to here, all the way. So all the four volumes, and the vital capacity is everything except the residual volume. Okay. All right, so let me see if I can erase this. Okay. So you can tell here again, so let's start out from the pen, it's not working. So here we have the volumes, 4 volumes, 2 capacities. 4 volumes, 4 capacities. So later on probably we are going to explain the expiratory reserve volume is the one who is keep maintaining the oxygenation of the blood even when we are doing, for example, expiration. And that is a very interesting part, but remember, we are going to be able to differentiate, knowing the lung volumes, what is the difference between restrictive and obstructive pulmonary disease. I will tell you, obstructive is, for example, asthma, COPD. Okay, and the restrictive is going to be fibrosis of the lung, or what we call cystic fibrosis of the lung. Okay. All right, so that is about that. How is going to be transport oxygen. So another thing that you need to keep always in mind, that hemoglobin plus oxygen are going to give you the oxyhemoglobin. Question, please. Open eyes, open ears. Oxyhemoglobin. How is going to be the name of the carbon dioxide associated with the hemoglobin? Is going to be the carbaminohemoglobin. The carbaminohemoglobin. Carbaminohemoglobin. What substance in red blood cells carries almost all the oxygen in the blood? Is the hemoglobin, right? What is the main form in which carbon dioxide is carried in the blood? By bicarbonate. So if you see here the reaction, we have a reaction of carbon dioxide that is in blood. Carbon dioxide, what mostly we have in blood is water too. So carbon dioxide react with the water, and the carbon dioxide with water are going to give us the bicarbonate. And that is the main thing, how the CO2 is going to be transported is going to transform into carbon dioxide. All right. So here we have again, if you see here, the simple diffusion is happening here, right? So here we have the venous return is coming back after they deliver all the oxygen. Is coming in blue. They're coming without oxygen, right? And here we have low concentration of oxygen, right? But when you inhale, coming in, you have high concentration of oxygen. So what we find here is high concentration of oxygen versus low concentration of oxygen. And remember that diffusion is going to pass from higher concentration to lower concentration. That is how the oxygen is going to pass towards the capillaries to the blood. Now, if that is another thing, here we have the carbon dioxide. So this is low in oxygen, but high in carbon dioxide, right? High in carbon dioxide. But when you inhale mostly oxygen than carbon dioxide. So here you're going to have low concentration of carbon dioxide, and here high concentration of carbon dioxide. So high to low concentrations where the carbon dioxide is going to go out and be exhaled by the system. The regulation of the respiration, we need to remember that we have a central and peripheral regulation of the respiration. Peripheral and central. Central, you know what's part of the central nervous system, and peripheral is away from the central nervous system. So regulation of the central nervous system, very simple, medulla, pons, medulla, pons, medulla, pons, medulla, pons. Pons have partially part of the respiratory center, but the main center control or main control center is going to be in the medulla oblongata, medulla oblongata, medulla oblongata. Nerve control is going to be medulla control and pons, but mostly the medulla oblongata. Then they go to the spinal cord, the spinal cord. If you see, we have the spinal cord, there you are. We have go to the spinal cord, and from the spinal cord they go to the diaphragm, diaphragm, and that is through the phrenic nerve. And who is going to innervate this is the cranial nerve number 10, cranial nerve number 10, pneumogastric nerve. So that is a cranial nerve who are going to be part of that. Okay. Chemical control, central chemoreceptors. The chemoreceptor, chemoreceptor means chemical, right? So that is going to respond to the levels of carbon dioxide. I will tell you something. Baby, when they born and how they know they need to breathe, right? How they said, okay, it's time to take air. They don't know. We don't know. So what happened is that at the time that we are disconnected, or let's put it, cut the umbilical cord, we don't receive any more blood oxygen. We don't receive any more oxygen from the mother side, right? So, and the lungs are not working because inside the uterus, our lungs are not working yet. So at the time we born, they cut our umbilical cord, and when they cut it, we don't have oxygen, so you start to be deprived by oxygen. So what happens in your body? Your body starts to accumulate a lot of carbon dioxide. So just close your nose, your mouth, and wait like 10 seconds, 20 seconds. You will feel that you need air, right? You need oxygen, and that is because you are accumulating a lot of carbon dioxide in your blood. And what is doing that? The carbon dioxide is going to stimulate the central nervous system, and is the central nervous system who release all these reflex in order to breathe in for the first time. So respond to the rays of uh, carbon dioxide. So carbon dioxide accumulation is going to make a stimulation of the central nervous system, central chemoreceptors. That's why it's called central chemistry receptors. And these receptors are for the amount of carbon dioxide. So if you have more carbon dioxide in blood, more carbon dioxide, that is going to make change the pH of the blood. So we are going to see that in a few moments. Okay, so we have peripheral receptors. So we already talked the central, we are located in the medulla oblongata and the pons, and the peripheral are located in the carotid arteries that we saw in the previous class. We have in the arch of the aorta. So carotid artery here, can you see these white dots in the, okay, again, so this is the arch of the aorta, this is the brachiocephalic trunk, this is the subclavian vein, this is the common carotid artery, and the common carotid artery divide into the internal and the external carotid artery, as we saw in the previous class. Here we have the next branch is the left common carotid artery raised directly from the arch of the aorta. This is the common carotid artery, internal and external carotid artery, and that is going to make the, in between they are going to have some receptors. These are the peripheral because are not in the central nervous system, that's why it's called peripheral. And they are going to be sending, where is that? What is that? This is the brain stem, correct? And what is this? This is the medulla, but here is a little bit dilated. That is the medulla oblongata. Okay, so the other ones are going to be located in the arch of the aorta. Arch of the aorta and the carotid arteries that respond to oxygen levels considerably below normal. So this in the central carbon dioxide, but here these guys are going to obey to the follow the levels or monitor the levels of oxygen in the system. Breathing patterns, so measuring breaths per minute. Adults is 12 to 20. So 12 to 20, 12 to 20, 12 to 20, that's what we need to remember always. Children and infants, they have the tend to have more breathing, more respiration per second. But at this moment, please remember 12 to 20. We have hyperventilation, so I put here as a reference as a NEA, so we don't use that word, but that means normal pattern of breathing. We don't use that word. Technically it's correct, but we don't use that word often, not at all. And I never heard somebody use that term, only as in textbooks probably. Anyhow, so we have here the hyperventilation. Hyperventilation, what is hyperventilation? You have, can you see, the breathing is more deeper, and high oxygen level. So that is what you're going to do. Hypoventilation is they're going to be decrease the blood pH. Increase the, when you have hyperventilation, your blood, you have more alkaline blood. All right, so I will tell you this. Look at this. When you have more carbon dioxide in your blood, when you have more carbon dioxide. So that means if you close your nose and your mouth for 30 seconds, you start to increase your carbon dioxide in your body, correct? So this carbon dioxide is going to react with the water And what they are going to do is when you have hypoventilation, right? Hypoventilation, you have more hydrogen. So when you have more carbon dioxide in your blood, you are going to increase the hydrogens in your blood. Again, more CO2, more H. More CO2, more hydrogens. More CO2, more hydrogens. And that is going to make the pH go down. So that means acidosis. And now if you are hyperventilating, you're taking all hyperventilating, what happens, you are sweeping out all the carbon dioxide from the body outside into the environment. So you have low levels of carbon dioxide, making your blood the opposite, to have less hydrogens. So you have less carbon dioxide, less hydrogens. Your pH is going to be alkaline. So that means your pH is going to be high. Okay? All right, so just remember, if you don't breathe, your blood become acid. If you breathe too much too fast, your blood become alkaline. And that is because of the levels of carbon dioxide. We have hyperpnea. So please, first of all, let's start with hypopnea. Look at this. Hypopnea is decrease in depth and rate of breathing. Let's talk about what is the difference between hyperpnea and tachypnea. Hyperpnea and tachypnea. This is the difference. This draw and this draw. Hyperpnea is increase in depth, more deeper, and rate of breathing. Hyperpnea. And tachypnea is when you have increased rate of breathing. Tachypnea is mostly happening when you have, you're going to have some infection, you start to breathe faster, superficially and faster, more superficial and faster. So that is probably a sign of a respiratory infection. Apnea, we have cessation of breathing. Dyspnea, difficult breathing. And I put this guy, because they are not resting. What they are trying to do is to breathe. What they are doing is put the arms on the chair, and that make support of his shoulder and diaphragm in order to breathe, to expand more the thorax in order to bring in more air. So that's why it's called orthopnea. Orthopnea, dyspnea while lying down. So when they lie down, they cannot breathe. So they need to sit up. They need to put their hands on the bed. They are bending over some table or something in order to give more support to the diaphragm to expand the thorax in order to have more air into the lungs. Palpitations. So what is palpitations? I put it here, is sensation of regular heart. So palpitation is the sensation, is a symptom. All right, so I don't know, this is hard. What is doing here is respiratory. Anyhow, so let's continue. Kussmaul, respiration, and chain stop. Okay, so this is important. All right, so let's start with the easy one, the chain stop. Chain stokes respiration. Chain stock is this breathing. Look at this. We have a small like a breathing. I don't know if you can hear. It's going to breathe like, well, I cannot see it. You cannot see me. But anyhow, so breathe superficially, then more deeper. So in crescendo, deeper, slower, superficial, more superficial, and then it's going to stop the breathing. Apnea, no breathing. So increasing, then decreasing, and apnea. Again, increasing, the depth of breathing, and then decreasing, and apnea. So that is a chain stop respiration. That is characterized for sleep apnea. Sleep apnea. So these people sometimes they wake up like totally scared that they feel suffocated. They are lack of oxygen, and suddenly they wake up. That is actually a sign of sleep apnea. Chain stock. A pathology that you can see here is the heart failure. Heart failure. In heart failure, you will see this type of breathing. Kussmaul, Kussmaul is more easy to remember. We have up and down, deeper, because the normal is this. What is the normal? This one, normal, and look at this, Kussmaul, more deeper, right? More deeper, and that is going to be representing a one very common sign for patient with diabetes. Is going to be metabolic acidosis. Metabolic acidosis. Okay, so metabolic acidosis, that means that you are trying to sweep out all the carbon dioxide to compensate the metabolic acidosis. So if you have, if you remember, I will tell you, when you have more carbon dioxide in blood, you have more hydrogens, right? More CO2, more hydrogens. The opposite. If you have less carbon dioxide, less hydrogens. So in this case, we have, in diabetic ketoacidosis, we have more carbon dioxide, more hydrogens. Okay? So if you have more carbon dioxide and produce more hydrogens, you have acidosis. So you have excess of hydrogens produced by the excess of carbon dioxide. So what you do in your body is trying to breathe deeply, more deep, in order to sweep out all the carbon dioxide of your blood. So that is going to try to compensate. So you decreasing your carbon dioxide doing this type of breathing, you're going to decrease the amount of hydrogens. All right, so let's keep going. So cyanosis, we have cyanosis is upper, sorry, it's the previous one. Cyanosis is when you have bluish discoloration on the skin, especially on the lips and the distal portions of your fingers and toes. Okay. Hypoxia is lack of oxygen supply. Hypoxia, so it's a hypoxic patient. It's lack of oxygen supply. And hypoxemia is different, is the oxygen deficiency in the arterial blood. Suffocation is the same to say asphyxiation. It's a long, prolonged time of apnea. So stop breathing calls also asphyxiation. Infections, we have URI, URI is the upper respiratory infection. That's why you need to remember the esophagus to the larynx is upper, the rest is lower. Common cold, respiratory syncytial virus, RSV, mostly happen in neonates, croup, larynx, and trachea. So here is this croup is dangerous. It can produce some problems. Croup, what is this? It's a viral infection. It's mostly para-influenza virus, what is going to have this kid between 3 to 5 years old. And they start to cough, and they're having like a bark, like a doggy, right? So the same sound, and the moment, and what happens is they are going to compromise the larynx and the trachea, larynx and trachea, and they are going to make narrow the airway. So that is very dangerous because they can die from a suffocation. And when to recognize that is when they have some strong sound at the time they're breathing out and breathing in. When they have two times this kind of very sounds on the whistling in and out, that is the moment that most likely we need to take the patient to suspect croup, and that is something that can be solved in the emergency room. All right, so we have high fever and asthma. What is asthma? Asthma is an obstructive disease, lung disorder that can produce. What is asthma, please? During inspiration and expiration. What is the problem with asthma? The inspiration or the expiration? The problem with asthma is the expiration. So you cannot exhale all the air that you have in your lungs because you're trapping the air there. So Why is that? Because if you cannot get all the air out, you cannot have new air. So there's less space for new air in the lungs. Make sense? So that is asthma. So these asthmatic people, they need to do exercises to squeeze, to exhale as much they can in order to the next breathe in is going to have more space to new air into the lungs. Otherwise, asthma at the end is going to end uh, into emphysema, so trap air in the lungs. All right, COPD. COPD is chronic obstructive pulmonary disease. And this COPD can be caused by asthma, it can be caused by emphysema, or it can be caused by bronchitis, chronic bronchitis, or the combination of two, or any combination of three of what I just mentioned. So COPD is the big umbrella, and asthma is not COPD, but asthma can lead into COPD with the time. Chronic bronchitis is not COPD, but chronic bronchitis can lead into what COPD. You can have emphysema. Emphysema is not necessarily COPD, but if they get worse, they can lead into COPD, chronic obstructive pulmonary disease. So those are these patients who carry this small device machine with them with oxygen permanently taking every time they go, right? Okay. So sudden infant death syndrome is also called the creep death. So and explain that recommendations about this back to sleep, tummy to play. So they suffocate themselves, or we don't know what can cause this suddenly I mean situation. Okay, so cancer, lung cancer is the most common cancer-related deaths. It's the #1 cause of death of cancers in the United States. We have about 220,000 people who has this cancer diagnosed every year. 220 new cases. How many will die? About 83% in the next year. 83% of the people who has cancer in that year are going to die in the next 12 months. Okay, so lung cancer, lung cancer. Cancer of the larynx is actually, here we have the vocal cords. Vocal cords is, oh, by the way, lung cancer, we have this kind of irregular cotton appearance in the X-ray. Those are fluid infiltrations that are going to let me think about lung cancer. Plus here we have some lymphatic nodes. But anyhow, lung cancer. Okay, so most common cause is the smoking. All right, so let's keep going. Pleurisy is, if you see here, this is the lung. The lung is having the parietal and the visceral layer of the pleura, right? So here we have the pleural effusion. So this fluid is in between the two layers. It's not between the pleura and the lung. It's between the parietal and the visceral pleura, where is going to be this liquid. Same here, we have the pneumothorax. Pneumothorax, instead of fluid in the pleural cavity. Pleural cavity is the pleural space is the space between the two layers, right? By visceral and parietal. Instead of water, we have air. And what means pneumo? Pneumo means air. If you have blood instead of water or instead of air, it's called hemothorax. So we have pleurisy, pneumothorax, and hemothorax. With age, basically everything is going to decrease. Elasticity and compliance. Compliance is, for example, if you have a balloon that is a balloon you blow in is easier to blow into air into the balloon. It's not that easy, right? let's imagine that they make a balloon that is hard material. So that is the balloon is the lung, so they cannot expand. So that is the compliance. With the time, the compliance of the lung are going to decrease. So that is the ability to expand through the pressure of the inhaled air. All right, so let's keep going. All right, so this is something that is extra. So I will really thank you very much for your listening this video. Hopefully it's going to help you, and I really appreciate your time. Thank you so much.